So we all know osteoarthritis knee is the commonly seen pathology in elderly. It occurs when the cartilage in the knee joint breaks down. So the various risk factors leading to osteoarthritis are genetics, obesity, muscle weakness, ethnicity, age, sex, bone density, sports, any kind of direct injury to knee. So early detection of disease help in reducing the morbidity, disability. So here in our study, we did a cross-sectional study which included 1,000 patients, including both genders. It was an institutional study in a private university. The age criteria was 50 years and above. Patients who had visited OPD and IPD were invited for the study. Inclusion criteria included patient with bilateral osteoarthritis knee having symptoms in both the knees, Kale Lawrence grading scale of 1 to 4 in both the knees in radiographs, visual Allen scale of the equal to 4 and above. Kale Lawrence classification we all know, grade 0, definite absence of X-ray changes of osteoarthritis, grade 2, doubtful joint space narrowing and possible osteophytic lipping, grade 2, the definitive osteophyte and the possible joint space narrowing, grade 3, moderate multiple osteophyte with definite narrowing of the joint space, and grade 4, large osteophytes with marked narrowing of the joint space. Radiographs were standard AP and lateral weight bearing. Patients with serious medical conditions like CVA, cancer and other chronic pain and other chronic diseases was excluded. All the participants signed an informed consent. The patient underwent clinical interviews, clinical examination of both the knees and bilateral knee radiography. To assess the pain, we used the Vieira scale. Our study shows this value as we have represented in pictorial format. So osteoarthritis of the knee is commonly seen in elderly. Pain is associated with elderly is not well understood. While comparing the clinical and radiological parameters in bilateral knee, we found mismatch between the clinical and the radiological finding according to Kale classification. Patient diagnosed clinically with bilateral OA knee shows a completely different radiological picture. It then becomes difficult to subject a patient to a treatment protocol based on X-rays alone. We suggest that further research is necessary to understand why clinical parameters do not correlate with the radiological parameters all the time. There is no correlation between the clinical and the radiological severity of OA knee. Hence, contemplating a knee replacement on the basis of X-ray alone cannot be justified. So conclusion, based on our study, we have come to this conclusion. Relatively males suffer at early age of osteoarthritis as compared to female. Medial joint line site is more associated with male at an early age of 50 to 69. However, the age of distribution is not different according to MGL site by the sex. Among the cases with swelling, the age distribution was comparably, while in the cases with no swelling, the age distribution was different. For both the sex, the VS scores are comparable by the different age groups. In other words, the VS score did not vary by the age group selected. For both the sexes, the KL score are comparable by the different age groups. In other words, KL score did not vary by the age group selected. About 30% of the subjects, the swelling was present. The percentage of the swelling did not vary significantly with the change in VS score. There is no association between the swelling and KL score. VAS score also did not vary with the sex. The alignment direction was symmetric in 87% of the patient. BMI was not related to OA severity in those with valgus knee, but related in those with varus knee. There is no association between the KL and the VAS score in unilateral or bilateral cases.